Good day. I'm Bjorn Ibsen, Professor of Anesthesiology at the Penn State University College of Medicine. And I'm here to tell you about my book, Leadership in Anesthesia, 5 Pioneers of the Deadly Quest for Surgical Insensibility. In this book, I tell the biographies of 5 protagonists of anesthesia, telling their histories from its start in 1846 with ether to its development from anesthesia to anesthesiology, the specialty, with Dr. Bjorn Ibsen devising anesthetic care in a recovery room. All of this I present through the lens of leadership, using the biographies of these 5 protagonists to explain leadership and divulge a certain amount of leadership insights that we might glean from their life stories. Starting with William Morton in 1846. He was a huckster and had been wanted in at least 3 states around the United States for swindling. He decided to become a dentist in order to try and find some form of financial remuneration, and so happened upon the idea of potentially using ether as an anesthetic to quell the incredible pain from teeth pulling. Where he got this idea is not 100% clear, but it's likely that he may have got it from Charles Jackson, who had told him that he should not use chloric ether, but rather sulfuric ether. Trying it one night on even frost in his Tremont Road dentistry rooms, he found it to be quite successful, and so was invited to give a demonstration at the Massachusetts General Hospital on October 16, 1846. His problem was that he knew that he was using ether, and ether had been around for 500 years, so he tried to disguise the ether by adding orange oil essence and called it lithium. And so he was invited to come and present this new anesthetic approach. But he didn't really have anything. He needed a discovery. So that night, the night before his presentation, he went and visited with a conchologist. That conchologist designed for him a device, this piece of apparatus that you see in front of you. This would now be an invention that would allow him to promulgate the use of this device to promote anesthesia. On the fateful day of October 16, 1846, fortunately for him, the patient Gilbert Abbott was tubercular and had a small tumor on the lateral side of his neck that he'd lived with for the last 30 years. The venerable surgeon J.C. Warren had invited Morton to come and demonstrate his anesthetic. So on the fateful day at the Massachusetts General Hospital, pictured behind me, everybody collected in the ether dome, which was at the top of the hospital. Surgeries were performed perhaps once or twice a day. And on the fateful day, Morton was late. The surgery had been scheduled for 10 o'clock, but by 10:25 he was not there yet. The reason was that the glass device that he had here and had never practiced with, he had dropped it, and as a result of it, it was broken, and so he had fashioned a new one for his demonstration, the first ever use of the device. He arrived at 10:25, went into the auditorium, and the who's who were collected around, including his previous patient, Eben Frost, to give him some support in this endeavor. He walked up to the patient, Gilbert Abbott, and said, "Are you anxious?" And Gilbert said, "No, I trust you completely." He asked Gilbert to inhale. Gilbert went off to sleep. J.C. Warren incised into the pulsating tumor in his neck, and the patient lay perfectly still, as was the whole auditorium, breathless with this event that was taking in front of them. Painless surgery. At the end of the procedure, the patient never having budged, J.C. Warren looked up at the auditorium, straightened up and said, "Gentlemen, this is no humbug." And that was the discovery of ether anesthesia, which took the world by storm. We now travel across to London via the Atlantic on the ship Apgar, where an article describing this surgical insensibility, the Insensibility paper, comes into the hands of the venerable James Robinson. James Robinson was a dentist who had heard about this new approach to anesthesia. And so he'd invited the who's who of surgery or medicine into his dentistry to witness the use of ether. And on one particular day, Dr. John Snow was there. John Snow had gone the traditional way of practicing medicine in England. And he availed himself of all of the opportunities to advance in the field. As he had studied respiratory care, he happened upon this procedure, this new anesthetic of ether. He immediately saw its potential, and so became one of the first protagonists of anesthesia, and also one of the first scientists. With the developments of anesthesia, he first popularized it around London, and of course he realized immediately that in a time of therapeutic nihilism, really where doctors could do very little good for their patients, here was an agent or a technique that really could do a huge amount, because it allowed surgeons to practice their surgery. Whereas before this had to be swift and fast, now they could properly take their time because the patient was not being tortured by pain from the surgical knife. John Snow went on to champion chloroform after ether. However, chloroform was a real killer, and this was one of the biggest problems that we had to face with ether, with anesthetics. And so John Snow ultimately wrote a number of books on chloroform and popularized it. Now, John was a peculiar individual. He was a vegan, and as a result of it, he sickened quite often. He may have had tuberculosis. He certainly had kidney disease. And in order to attempt to design one of the safest anesthetics that he could, he imbibed many of the test substances himself, sickening himself even further. To his last day, when he completed the text on chloroform, he stood up, keeled over, and died within the next 5 days, literally working himself to death. We pick up the story with Arthur Guedel in the early 1910s on the Western Front. Arthur had trained to be an anaesthetist at a time when the specialty had not yet existed. And on the Western Front, he set about helping to provide and educate around anesthesia for all the troops that served in the war effort of World War I. In order to do so, he set up a number of base camps, clinics, where surgical services could be provided, anesthetic delivered, particularly with ether and chloroform. And in order to monitor that patients were getting safe anesthesia, he designed an anesthetic chart. And this anesthetic chart took off from the work that Snow had previously described and made it quite clear and simple how one can assess the depth of anesthesia. This would allow people who were not yet fully trained in anesthesia to give anesthesia safely. And so he used this anesthetic chart or pocket chart to basically allow multiple people around the Western Front to give as safe anesthesia as possible. In order to monitor that this was the case, he would drive around on a motorcycle and hence was known as the motorcycle anesthetist. Now at the age of 13, he cut off 3 fingers from his hand as a result of a sawmill accident. But despite this, he became one of the most astute equipment designers in anesthesia. One piece of equipment that he helped design was the cuffed endotracheal tube, Previously, McGill rubber tubes had been used to intubate the patient, but he wanted to design a cuff around it so that gas would not escape past the endotracheal tube in the trachea. So together with Ralph Waters, they designed a cuff around the endotracheal tube which would occlude the airway, and as a result, no gases would escape from this. Now, they had a wonderful design, but the problem was nobody was adopting it. So in order to have it adopted, he decided to develop a demonstration, a dunked dog demonstration. On one fateful day, he had an aquarium on the one side of the room, half filled with water, and he had his dog Airway. He anesthetized Airway, the pet dog, intubated the pet dog Airway with the cuffed endotracheal tube, and then inverted the dog in the aquarium underwater for all to see through the aquarium windows. The dog lay anesthetized underneath the water with just the endotracheal tube and an anesthesia device, much like this, lying outside of it. And for the next hour, was managed safely under anesthesia, its pulse rate and blood pressure hardly changing. At the end of the experiment, they withdrew Airway from the tank, laid the dog down, took out the tube, he wagged his tail, shook his body, shaking all the water droplets off, and walked out of the auditorium to loud acclaim. The rest is history. After this, of course, people started adopting endotracheal tubes with the cuffed airway occluded to allow better ventilation of the patient, as well as to avoid the aspiration of fluids into the lungs. We move next to Virginia Apgar. Now, Dr. Virginia Apgar had been passed over to become the chair of anesthesiology at the Columbia University Physicians and Surgeons. However, she decided to take this in her stride and instead became the first obstetric anesthetist. Here in the early 50s, she identified a key problem, and that was the death of the newborn. The problem really was that when a mother delivered her baby, all attention was focused on the mother. So the baby, the just delivered baby, was put in a bassinet and ignored. The baby would take a few weak breaths, would falter, and then stop. Meanwhile, attention was paid to the mother. The afterbirth was removed, intravenous fluids were administered, and when people looked around again at the little baby, the baby was dead in bed. The first 60 seconds after birth was critical. So Virginia decided to act. She developed a newborn baby score, a scoring system that would mandate that the accoucheurs would look at the baby immediately after birth, telling off the score of color, grimace, heart rate, respiratory rate, so that attention was focused on the newborn, and if the newborn was not well, interventions, resuscitative measures were put in place. This eventually became the Apgar score in 1961, which is now used for every baby around the world. Finally, we go to Dr. Bjorn Ibsen. Bjorn Ibsen was one of the first anesthetists in Copenhagen in Denmark. At the time, in the early 1950s, Copenhagen was beset by a terrible polio epidemic. Polio was killing the patients by causing respiratory paralysis, as well as an accretion of secretions which caused pneumonia in the patients. Dr. Ibsen had been asked to help because the epidemiologist running the hospital was at wit's end as to how to manage these patients with respiratory failure. They had at the time used iron lungs, basically vacuum tubes in which they would place the patient on a trolley. The vacuum tubes and their necks were cinched down with a collar, and the vacuum tubes would expand and collapse in order to allow the lungs to breathe for the patient. However, they didn't work. And on a fateful day, Bjorn Ibsen was asked to look after a patient by the name of Vivi Ebert. She was dying of polio. Therapy in the iron lung had not worked. And they asked to see whether Bjorn could perhaps devise an approach to managing this critical problem. So he said, I will take the case on and I will see what I can do using techniques that I've used in the operating room. So on the fateful day, the who's who of the hospital gathered around. He withdrew Vivi Ebert on the trolley from the iron lung and asked the ENT surgeon to perform a tracheostomy, which he did, and intubated Vivi. And then the trouble started. She went to acute bronchospasm and started deteriorating, becoming blue. All present thought that this was going to be another terminal event, and so they disappeared, while Bjorn Ibsen battled with the problem. And then he provided the master stroke. He gave Vivi a bolus of thiopentone, an induction agent, which immediately stilled her bronchospasm, calmed her down, and allowed him to ventilate her using a bag and bottle device that we use regularly in anesthesia in the operating rooms. He then summoned everybody back, and they came and witnessed the effect that he could resuscitate these patients using anesthetic techniques, so taking us anesthesiologists out of the operating room. The very next day, the head of the hospital drafted 250 medical students to help ventilate up to 50 to 70 patients a day in 6-hour shifts to help recover from this polio epidemic. It is said that this approach saved over 100 lives. And from this approach of managing respiratory failure within a particular unit came the first intensive care unit. And that first intensive care unit was created by Dr. Bjorn Ibsen, and hence he is known as the father of intensive care. Having gathered all of these stories of these 5 protagonists, I then provide a leadership assessment of how they have performed as leaders of the field, using a number of criteria that have stood the test of time. Leadership criteria that were first written about by C. Northcote Parkinson in his book, The Law of Delay. I have created a skeleton of leadership activities in order to dissect down for each of these 5 protagonists how they performed their leadership skills. Skills like creativity, change management, what credibility or legitimacy they had, and what empathy they had. And in the final chapter of this book, which I call Leadership Reckoning, we contrast and compare all of their different leadership skills that these pioneers of anesthesia have displayed during the course of the historical development of anesthesia to anesthesiology. And I come to a seminal conclusion, which is that leadership is like beauty. It manifests very differently in different individuals and circumstances. But nevertheless, leadership can flourish. Thank you very much for your attention, and I hope that you will read the book and learn more about the terrific history of anesthesia and anesthesiology.